Well, welcome to this talk, and a really warm welcome to Dr. Joseph Freeman, all the way from Louisiana. So, Dr. Freeman is an emergency physician and also a author. Dr. Freeman, welcome and thank you so much for coming on.
Oh, it's my pleasure to be here.
So, you're a busy doctor. You're an emergency physician in Louisiana, working in different areas. You work shifts. And somehow you've found time to do this excellent reanalysis of the original publications of the safety data from the Pfizer and the Moderna vaccines. What stimulated you to look into this and to do this reanalysis in the first place?
Well, initially I was, prior to COVID also, I was doing research, and then with COVID coming on, of course, that became the topic. Everything else got thrown to the wayside. And when the vaccine was released initially, I had gone over the full FDA briefing for both Pfizer and Moderna, published in a physician website, basically a summary of what they had discussed in the large briefing. And initially, I didn't have any specific safety concerns based off of that data. It was more I had some general concern for a novel platform that had limited safety testing, but it was very non-specific of what harms there could be. Just that the knowledge that sometimes we learn about harms, frequently we learn about harms with time that we've had from when we approve a drug, and that's for drugs that have gone through many years of safety data testing. So it was just a general concern that I had. And then in April 2020, which is about 4 or 5 months after the vaccine was authorized, came this 2 large studies that together sort of confirmed that the spike protein was toxic, and that it was causing all these weird things that we'd been learning about for the last year and a half, I guess, at that point, about what COVID can cause. All these strange things: heart attacks, strokes, the diarrhea, the stomach issues, all sorts of different issues. And I was sort of shocked by that finding, because we'd made a vaccine that makes our body produce spike protein. And that was really bad luck in my mind. If we had known that the spike protein was toxic when they were building this vaccine, I doubt they would have used that as the go-to protein. So that was my initial concern. Then the follow-up concern was the public response to this discovery, which was saying things such as, oh, the spike protein in the vaccine is different than the spike protein in the virus. And my thought was, well, that's not good either, because if it's different, then it won't work. It has to be the same. That's how this whole thing sort of works. And then there's this idea that it just stays in your arm. And at the time, there wasn't good biodistribution data. And in general, as a physician, I mean, if you inject something into an arm, it's pretty unusual for it to stay in the arm. And if we're just boosting it over and over, is that all just staying in your right bicep just keeps getting bigger and bigger from the amount of injections? It didn't make sense. We later learned there was biodistribution. And then at the same time, there was also a CDC myth website where it would saying that the COVID vaccines, the spike protein that the vaccine produces is toxic, is a myth. So I felt like the response to learning that the spike protein was toxic should have been a moment like, put your seats up, the plane, we're coming in for a crash landing. This is a problem. We need to figure this out really quickly. But instead, it seemed like it was just dismissed. So initially, I put together this idea of a study to create a list of spike protein harms and see if the vaccine is inducing spike protein harms in the trial. Given it was called a myth by the CDC at the time, we felt that it was not going to be looked kindly upon to have a spike protein list. And so what we found is this group called the Brighton Collaboration.
Yeah.
That had a list of adverse events of special interest. And the list included, we had created an actual list for the COVID spike protein. And most of them were contained within this AESI list. And it's because of how they create it. They look at all the things that COVID had been responsible for. In addition to that, they are looking for possible harms of the lipid nanoparticle and just what we'd expect from various other vaccines in the past. They create a list of things that are potentially caused by the vaccine. We don't know they are. It's done before the clinical trial. They're supposed to be used within the clinical trial to look for if this vaccine is causing harm. And so we took that list. It's endorsed by the WHO to reanalyze these clinical trials to examine for the possibility that they could be causing harm.
So AESI, adverse events of special interest. And who actually are the Brighton collaboration? Who are the individuals involved here, and where did they get their authority from?
Oh, they've been creating these adverse event lists, adverse events of special interest, for some period of time, and they're essentially experts in vaccinology. They have a pretty good track record for identifying harms of vaccines that prior to the clinical trials, and so they've been pretty reliable. It's why the WHO has endorsed them for using that list for evaluating vaccines.
Yeah, it's an established group of experts, isn't it?
Mm-hmm.
Now, you conducted a secondary analysis on the original trials that were conducted by Pfizer and Moderna, these phase 3 randomized clinical trials in adults. And these, of course, were infamously, both published in that definitive text, the New England Journal of Medicine. Mm-hmm. Can you tell us just roughly what sort of trials were done? What is a placebo-controlled phase 3 trial, and what is a secondary analysis? Was there something wrong with the primary analysis or something?
Oh, so a clinical a double-blind randomized trial, you compare a medical intervention and then you have versus a placebo group where everyone's supposed to be blinded and not know. And then ideally, if for the FDA, they advise that they should be designed to have the outcome be clinically meaningful. And while they're doing it, they're also looking at various other things. So there's lots of data that they produce. And secondary analysis takes that data and applies a different question or applies it in a slightly different way to see if the results would be the same as the initial trial. And so it's a common practice that's been done for clinical trials for as long as I know of. So that's the general idea of it.
Yeah. Now, you identified excess risk in the vaccinated group as opposed to the non-vaccinated group in terms of adverse events of special interest. What do we mean by excess risk? Surely there's a risk with anything. Oh,
excess risk means so we're looking at serious adverse events that was our specific analysis. Serious adverse events are defined by Pfizer and Moderna, very much the same. It leads to death or life-threatening. It's hospitalization, permanent disability. These things are serious, and it's their definition, serious. But they are all serious things that you wouldn't want to happen to you. So when you look at the clinical trial, we just simply collect that data from on serious adverse events. We count them, we pull them all from the data set. And then we have the list, we count them basically in both of the charts, and then essentially we do the secondary analysis of it, which would be the AESI list of looking at which ones would fit, of those serious ones would fit into this AESI category. And what we mean by excess risk is there, so you'd expect serious adverse events, for example, heart attacks. They're just going to happen. There's study has 40,000 people.
Yeah.
Do more happen in the vaccine group is what an excess risk is, because both groups will have heart attacks no matter what, but are there more heart attacks? Are there more strokes? Are there more, is there more, anything that is a serious adverse event in the vaccine group is what an excess risk would be.
I mean, I do find it a pity that this wasn't done and presented in the original papers in the New England Journal of Medicine. It's a pity that independent academics such as you had to do this. Were you asked to do this by the pharmaceutical industry, or were you funded or sponsored in any way to do this?
No, there's no funding at all. This is all every clinical. There are 7 of us, 7 scientists working on this. No one was paid in a single dime. It was all done with our free time.
And it's just moving that experts such as yourself do take the time to do this for the benefit of all of us. So we certainly appreciate what you've done, and while being sad that it's necessary for people like you to do this. But it's a great thing to do. So Pfizer,
if you went into science, there's it's a calling to do science.
Yeah.
Finding people, it wasn't a problem finding. There were people who were concerned and interested in this project, and they all volunteered. And that part doesn't really surprise me, that there are people volunteering, especially with the concerns that I was raising before, that there felt to be a lack of an investigation. So people felt the need to put their skills that they've trained with their whole life for the benefit of everyone else.
Yeah, no, it's still a noble thing to do. It's a great thing to do. Going on to the results, Joseph. Pfizer vaccine excess risk of serious adverse events. So this is how much more likely there was to be a serious adverse event of special interest in the vaccine group versus the placebo group. Now, it's 10.1 per 10,000 excess adverse events, higher than the placebo baseline where it was 17.6. So it's 10.1 higher. Now, I've kind of just done a simple sum. I'm not a statistician, really, but 10.1 for 10,000. Is it fair to say this transposes into one serious adverse event per 990 vaccinations with the Pfizer?
Yeah, that is definitely about the estimate of what that would be. I think it's for all of these increases in excess risk. I think it's best to almost think of that 1 in 900 that you're saying there. These are estimates, and if you did the trial again, it would be slightly different. So there's a range of possibilities. It could be 1 in 800, it could be 1 in 1,000 in there, and that's for adverse events of special interest. The thing that was actually the most shocking finding of our entire study to me, and I think to the rest of my team, was when we just added up all the serious adverse events in the trial, there was a higher incidence of serious adverse events, not adverse events of special interest. Just they didn't have to do any analysis. They just needed to count. If they just counted the number of events in both groups in the Pfizer trial, you see that there's an increase of about 18 in 10,000 and relative risk or risk ratio of 1.36.
Yeah.
And so that's a 36% increase. Our confidence intervals are all above 1, which suggests with the 95% arbitrary, the threshold is 95% that we use, and it means that in the Pfizer trial, that the people in the vaccine group were more likely. There was more serious adverse events in the vaccine group than there were in the placebo group, and the reason that was missed is because the surprising thing is, if you read the New England Journal, it says that the incidence of serious adverse events in both groups was similar. I believe that's the term they use, was similar, or they say balanced. But that's a very strange way to describe something that's higher in the vaccine group. And
it's a very strange way to describe it indeed.
Yeah. So we actually wrote the New England Journal about that and asked them to correct this, because the term, they say the incidence of serious adverse events is balanced or similar, and we asked them to change it to say that it's higher in the vaccine group, because that
patently it is from your reanalysis.
Oh, it's this one's not even a reanalysis as much as just counting the there's not much. We just did the math for them that was there. It's not
Yeah.
Not much reanalysis needs to happen. And you know, I believe that the reason they maybe stated it as such was because it's an error in that they were trying to say the incidence of participants who experience a serious adverse event is similar, because if you look at the way you can measure these things, we just counted the number of events. Yeah. They counted the number of participants who experienced one. And so there's, you know, a 27% increase in the number of participants who experienced one, but it's confidence interval, which, you know, would be the statistically significant term. It wouldn't cross it. It would be, you know, it would cross that confidence interval. Mm-hmm. So maybe that's why they felt they can say it, but either way, it's stated incorrectly in the New England Journal as of today.
You're a very generous man. I can see that in the way you evaluate that. The Moderna vaccine's risk of serious adverse events, 15.1 per 10,000. And that works out at 1 per 662 vaccine doses given.
Mm-hmm. Yep.
Even higher. Combining the two, it works out at 12.5 per 100,000. So basically, one chance in 800 of a serious adverse event. Is this sort of risk commonplace in medicine? Do you take these risks on a daily basis as you prescribe for your patients, or would you think, well, just a minute?
Well, it depends on the drug. So, you know, for a chemotherapeutic, I would imagine the rate for a serious adverse event is much, much higher than that. Yeah. But for a vaccine, at least the CDC reports that the rate for most vaccines is about 1 to 2 per million. So this is a multifold difference in serious adverse event rate.
Wow. So we've gone from 1 to 2 per million to 1 to 800, which a quick sum in my head is like 1,200 times more common.
Yeah, it's definitely, it is way worse. It's definitely a
incredible.
Lot more.
Yeah, it's like 1,000 times worse by those criteria.
Yes, it is.
Wow.
If you want to do the math, 1,000 times worse.
Yeah. Don't take my mental arithmetic for that, but it's an awful lot more. So you also gave a reanalysis, you said, in terms of risk ratio. Just briefly, what is risk ratio, please?
It's essentially a relative risk, how you would report relative risk. So for the way you would interpret that would be 1 point. If you're in the vaccine group for with the Pfizer vaccine, or we could do the combined one, which was off the top of my head, what was it? 1 point.
The Pfizer's 1.36.
1.36, yes. Okay,
yeah,
so
the Moderna's 1.06, and the combined is 1.16. So combined, it's 16% more likely to have an adverse reaction.
16% more likely, yes, exactly.
Yeah,
1.36 times 1.16, yes. The way you interpret a relative risk is you take that number and you say it's 1.16 times the risk of, it's 1.
Yeah. But it's still fair to say that the combined figure is a 16% higher risk of getting an adverse reaction.
It did, and there's reason to believe that within the Moderna trial that we are concerned that there are serious adverse events that are hidden within it, mostly in the placebo group that were from COVID-19, caused by COVID-19. And typically for a safety analysis, you are supposed to remove the efficacy outcome. Or you create what's called an all-cause outcome, like an all-cause hospitalization. And it's not that all-cause outcomes aren't useful. They are useful. But when you're doing a safety analysis, you just want to look at the harms and so you are supposed to remove efficacy. COVID-19 being an efficacy outcome, serious COVID-19 being an efficacy outcome. Pfizer did remove that, and Moderna did not. We attempted to remove those COVID-19 cases from Moderna. However, the problem is that with COVID-19 serious outcomes, you could end up with multiple serious adverse events from COVID-19 that would be still littered within there that we weren't able to identify because we didn't have the data to identify it.
So when the Moderna data is showing 6% greater risk of serious adverse events in the vaccine group, and the Pfizer is showing 36%, that's comparing apples with oranges. Then it's a different methodology of collecting the data.
It is, and we've been speaking with the FDA and also with Moderna. First with with Moderna to try to get this data so that we can actually look at it with that efficacy outcome removed, and also ask the FDA why they allowed Moderna to run their safety analysis in such a manner differently from the Pfizer, because and without any mention that it was run differently. They should have at least mentioned that it was different. I'm not sure if it was unnoticed, or I'm not 100% sure why Pfizer and Moderna analyzed their safety data slightly differently.
Well, for the amount of money and amount of expertise at the FDA, it's quite an oversight.
Yeah,
I would have thought.
I mean, they were quite rushed, and it's the kind of thing that if it took us several months to identify that issue,
Yeah.
So they had to approve this in just a month or two. So it wouldn't surprise me if it just didn't get identified because of the how quickly the vaccine was authorized.
Yeah, but it's their full-time job and it was your part-time job. So and you picked it up and they didn't, is the point. So
fair.
Yeah. So you suggest a formal harm-benefit analysis. What is a harm-benefit analysis, and why are you suggesting that this is done?
Oh, so a harm-benefit analysis simply is you try to take the harms that are any intervention is causing. You look at the benefits and then you compare them. There's lots of issues always with harm-benefit analysis, and because for a drug that prevents heart attacks, for example, right? It just so turns out usually that whatever harms that drug causes, it's probably not increasing heart attacks too. So you can't just compare heart attacks and heart attacks, because that's just the benefit. And so then there becomes a lot of subjectivity in terms of how do you compare, and there's been lots of different methodologies to do it. One way would have been great if the vaccine trial had this, would have just been to look at all-cause hospitalizations. Who got hospitalized? Yeah. Who got hospitalized the least? Which group?
Obviously.
It's in fact for Paxlovid, Pfizer's Paxlovid trial. That was actually their primary outcome, was all-cause hospitalization. And in the vaccine trial, we still don't know the all-cause hospitalization rate from that trial. It's never been made public. So that would be one way that would be useful. If we could just get that data released, that would be useful to understand if the vaccine were hospitalized way less than the vaccine group. Oh, that's that's great. If the vaccine was reducing all-cause hospitalizations, it's working. But if the vaccine group has higher rates of hospitalization, then that would be pretty concerning. Or if it's just too small of a trial to identify it and it's a null result, that would not be useful either way. But either way, I think the data should be public.
Well, we've got reason to believe that Pfizer and Moderna will be watching this video. So as soon as they hear this, no doubt the data will be in the post to you, and you can carry out that
I would hope.
analysis. Let's hope.
I would hope. But for the harm-benefit analysis that we did, we took the adverse events of special interest.
Yep.
And we compare the excess risk that we were identifying, because these are all things that are considered serious, life-threatening, hospitalization, permanent disability. I presume that the large majority of them were due to hospitalization. And then we compared it to COVID-19 hospitalizations, and people critique like these are not the same, because some of the hospitalizations, for one thing, won't be as serious as a COVID-19 hospitalization, but in reality. There are some minor COVID hospitalizations. In fact, probably the majority are. And then there's some ICU level intubations, people intubated in the ICU. And the same would be true for the serious adverse events. Some people had a stroke, and that's pretty devastating. And some people just had, diarrhea that was so severe they needed to come in the hospital to get IV to prevent them from dying from dehydration. Yeah. And they probably walk out without much. But in that harm-benefit analysis, what we identified from within the trial is that the rate of serious adverse events, the excess risk for special interest group, they're higher than the reduction in in COVID-19 hospitalization. So within the trial, it looks like you were more likely to have an adverse event of special interest in the vaccine group than you were to have a COVID-19 hospitalization reduced. Now,
Wow.
when I talk about that harm benefit analysis, it's important to understand their limitations to how we can interpret it, I think. And it's important to mention those because, let's say the trial had gone on for 6 months. Maybe then we would have seen the hospitalization reduction increase. Maybe if there was a COVID-19 surge, the hospitalization rate would have been, and it would have balanced it out the other way. Or maybe if they just did older people, maybe, older nursing home patients, maybe the hospitalization reduction would have been increased and it would have tilted it towards the vaccine being beneficial. However, had the trial been done in younger or healthier patients with less hospitalizations to reduce, or during Omicron, when there's less hospitalizations to reduce, or Omicron where the vaccine is known to be less effective. And in that situation, the harm benefit analysis would tilt in the other direction towards more harm to benefit. And I think that when you consider that, there's different ways that this can go, I think that the harm benefit analysis we put forward simply demonstrates the fragility of this harm to benefit ratio and how just the slightest differences can alter it in one way or the other. And that in itself should be concerning.
The odd patient being excluded could make a huge difference to the overall data. So to adjudicate whether the risk-benefit analysis is affecting a particular age group or a particular sex, you would need to have that information. You would need this participant-level data. Has that now been released?
No. The participant level data, which means knowing the serious adverse event that each person had, their age, their sex, any sort of demographic information we have on them. No, we don't have that. That hasn't been made public. We've actually asked. We sent an open letter to the CEOs of Pfizer and Moderna. It was published in the BMJ, asking for this data. It would be necessary for us to help us to do some subgroup analysis, because maybe these adverse events are happening in that elderly at-risk group, and maybe the benefits are outweighing the harm in that specific group. Maybe they're if they're spread throughout, then maybe it's problematic in the younger people. But it's difficult. We can't make much of any sort of subgroup analysis without that patient level data, and that's why it would be important to make it public.
And yet the drug companies have this data, they just don't release that data to independent researchers such as yourself.
Yes, the drug companies and the FDA have it. I believe for some reason the European EMA does not have it. They do not have it. We had asked them for it as well. They have to put in a special request for it, they said to us. But FDA has it as well, and they also have not released it to the public.
Well, FDA, if you're watching, get Dr. Fryman this data ASAP, please, so we can analyse it. Then we'll all know. Because that might mean that a particular intervention is less appropriate in a particular age group. But unless we have the age group data, we don't know. Or
it could mean it's appropriate for everyone. We don't know. Maybe it's great. But I don't know exactly what the data will show. We don't have it. We'd have to figure out what it. We'd have to determine what it shows after we obtain it.
Yeah, I don't like the secrecy, but there you go. That's what we have. Now the results of the initial trial were to do with the likelihood of getting infected with the virus, and they expressed this in terms of a relative risk, vaccinated versus unvaccinated. Do you think it would have been a good idea if they'd given some indication to absolute risk as well as relative risk? And could you maybe just sort of pick those two apart a little bit for us, please?
First, it was a reduction in symptomatic infection, not infection. And
yes.
so essentially it was like COVID-like, cold-like symptoms, essentially, with a positive test. They didn't do just weekly testing, which would have been in my opinion, a superior way of judging efficacy. Or it wasn't reduction in hospitalization, which also I think would have been a better way of running that trial. It was symptomatic infection, which has some subjectivity in it. And but the relative risk versus absolute risk, the distinction there is they said 95% reduction in symptomatic infection. It was relative to the placebo group. So I think in the vaccine, and it was about, for Pfizer, I think it was like 162 versus 7. I might have my numbers slightly off there, but it's about that. So the relative risk was 95% less. Now, an absolute risk would have been looking at, okay, what was the risk of infection in the placebo group and the vaccine group, and so there were 20,000 or so people in each group. So it was, point something percent versus a smaller point. It was a decimal. It was a fraction of a percent of infections that it prevented. And that, when you talk about it as absolute risk, this is a long held debate within, very, very nerdy confines of medical statistics and medical communication. But the reality is both relative risk and absolute risk have value. They should both be discussed to get a better understanding of what you're dealing with. I think with the COVID vaccine, there was maybe a reasonableness to talk about the relative risk, to emphasize it more, because I think at the time they believed that this vaccine would be two and done, and that we would have the vaccine efficacy for the rest of our lives, like most other vaccines. And so if you say 95% effective, that actually is a better way of determining that if they were correct with their hope, if their hope was correct that the vaccine would just last for 20, 30 years, then you'd say, look, over the next 20, 30 years, you get this 95% benefit, which, you don't do a trial for 20, 30 years. However, like for example, if the trial had gone on for 2 to 3 years, and I think that absolute risk then wouldn't be that. I worry that to do it with the 2-month data, it could be a little misleading if the vaccine
would be way below 1% efficacy.
Yeah, but let's
if
say
you
the
did it over
trial
2 years, it could have been higher. Yeah.
Yes, exactly. If it's 2 to I think a great thought experiment, hypothetical, is if the trial had gone on for 2 to 3 years, and we were looking at all-cause hospitalization, the point that they still haven't released yet.
Yep.
Now, it looks to me that the vaccine does increase some hospitalizations, likely from, as we see in our study, at least for certain, it looks like that in the Pfizer trial. Now, if we looked at that over a 2 to 3 year period, and presuming that the vaccinated group would get boosters whenever the CDC decided it was a good idea for them to get them, or maybe they could have actually, let's say they even figured out the correct timing for boosters with trial data, that would have been useful. But imagine such a trial was done and it was done perfectly. Over 2 to 3 years, would there be a reduction in all-cause hospitalization? Because that's the question that actually people want to know the answer to, is if I take this vaccine and I take it how I'm supposed to, do I go to the hospital less? Do I go to the hospital more?
Sure.
At 2 to 3 years, I believe that the problem with that is, well, first off, is that we don't know the answer. And I don't think anyone can be certain on the answer to that, especially given that we know the massive, rapid waning of the vaccines, and then you compare that with the fact that people post-infection have prolonged immunity much longer than the vaccine. Yeah. Then Omicron comes in, and the vaccine has reduced immunity. Once we had this whole infection, it's not reducing infection anymore. It's just reducing hospitalization and death, which was based off of observational data, which is not a good way to determine the efficacy of a drug. And that has gotten us into complete mistakes so many times in the past. So if that trial had been done, the big thing is we don't know the answer. And but it would be useful. I wish it had been done so that we have the answer. We would know that we're giving someone a medication that is to their benefit. That would be great.
So the initial trial was preventing symptomatic infection. Then you could say that the goalposts were moved to say it prevented hospitalization, but we don't have the all-cause hospitalization data. So,
well, also the thing that concerns me about this is if you look at the infection mortality rate, I guess you can say, or infection hospitalization rate in the clinical trial, in the vaccinated group, their infection mortality rate and their infection hospitalization rate is not lower. It's not lower than the placebo group. It looks to me like in the clinical trial that the way that the vaccine reduced hospitalization and, well, we didn't see death and mortality improvement, but the way it reduced hospitalization was probably by preventing infection initially. So if it stops preventing against infection, biologically, I just don't see how it then gained a special ability that it didn't have in the clinical trial to reduce hospitalization. And I would be concerned that in an observational study, looking at hospitalization, that you'd result in something called you could have something called a healthy user bias, where, as was shown in even to be occurring with the COVID vaccine, in a New England Journal response from Vinay Prasad and Tracy Beth Hogue, where they were showing that this healthy vaccine user bias could account for the entirety, possibly, of the benefit.
So that's people who were healthier anyway elected to be vaccinated at an earlier stage. Sort of. It's healthier people elected to, but also people who are on hospice, who are about to die, don't really get it. Or if you're in the ICU right now, you wouldn't necessarily get it. So you see a strong healthy user bias, especially probably in the first 6 months after a vaccine is going to be distributed, and then it's going to decreases with time, which is sort of exactly how this hospitalization benefit appears to be occurring. And I don't know if it's it's possible that the vaccine is having great hospitalization benefits, but we don't know how to adjust for this healthy vaccine user bias. So I think people should be concerned that we are unaware, we're uncertain if the vaccine is reducing hospitalization and death in the manner that it's being. I feel it's sort of being reported in that with this certainty, this level of confidence of we know it's doing this. And we don't usually speak like that, or shouldn't speak like that in the medical community about the efficacy of any medical intervention, that we're basing it on observational data. We just keep getting that wrong. We've gotten it over and over again wrong. And often those interventions, when we get it wrong, when we look at it, we find out it's doing the exact opposite. It's harming people. When we were, for hormone replacement therapy being one of the most famous examples, we thought it was reducing heart attacks, strokes, and breast cancer. Did a randomized trial. Whoops, it was increasing heart attacks, strokes, and breast cancer. Yeah, indeed. So medical history is useful for knowing how we need to learn from history, that is for sure. Yeah. You're very honest in your paper about the limitations to the follow-up time, but that wasn't your fault. That was the way the studies were done. Serious adverse events. Who adjudicated what was a serious adverse events? It seemed to be mostly the regulators. You didn't have the raw clinical data, you didn't have the blood results, so you could adjudicate yourself. You just had to take the regulator's word for what was a serious adverse event.
It was regulators, but I actually don't. I believe that it was actually the clinicians on site who were working with the companies hired by Pfizer and Moderna would be the ones who would educate them. But they were supposed to have been blinded to these results. So they shouldn't have known if they were in the vaccine, or it's possible that there was some unblinding and they may have known a little bit, but it turns out that the participants had a pretty good idea, it seems like, which group they were in based on some side effects that they experienced.
And of course, what is a serious event is subjective to the individual. Is that old joke in medicine that a minor procedure is any procedure carried out on someone else? It's easy to say it's minor when it's someone else rather than yourself. This is not that. A person thinking that an adverse event that occurred to them was serious is not relevant to what
is called a serious adverse event.
Yeah.
It has to be called a serious adverse event by a clinician.
Got it.
So it's, but yes, you're correct in that people have things that are serious to them.
Yeah, sure.
That wouldn't make it into this grouping.
Yeah. And we've already talked about the lack of participant level data, the difficulty with full transparency, and the lack of detailed clinical data. So all those things that were limitations for the study, I think, were completely out of your control.
Yes, how long the study was, that is one of the critiques of our harm benefit analysis.
Yeah.
There was, you would see someone who has a blog or tweeting that you can't possibly do a harm benefit analysis based on 2 months of data. And I'm concerned if they believe that, then why would you authorize the population to take a drug if you can't do a proper harm benefit analysis? That seems so. I suggest. I mean, I don't know if that individual thinks that the trial was too short to have been authorized, and we should have waited for more data before authorizing. But that was their critique of our harm. That is a common critique of our harm benefit analysis. Yeah.
Just as a clinician, Joseph, are you seeing many patients admitted with COVID now in your sort of day-to-day practice?
No. Back, in the first couple of surges, it was my entire ICUs were filled with people very sick with COVID-19, the classical syndrome of COVID-19. Yeah. I was responding to 2 to 3 of these rapid responses a day. When I work at night, I'm the only physician in the hospital. So anytime something goes wrong. So I have a very good finger on the pulse of what's going on in terms of, people getting real sick, people dying. I have to pronounce every one of them. And first couple of surges, I would see 2 to 3 a shift, and typically it would be one every 3 or 4 shifts. So this is a massive increase in death and devastation, I guess. But since the Omicron variant, the interesting thing was prior also it would go, I'd watch the news, increase in infections, walk into work if I'd been a couple of days off, like, oh yeah, infections are increasing, I'd see it. Hospitalizations increasing. Oh yeah, that's true, hospitalizations are increasing. Deaths are increasing. Yep. It was like the weather. It's like when you walk out of your house, you look at your phone, 70 degrees. Oh, that does feel like 70. I can't say that the numbers are 100% accurate, but the direction, when you saw things increasing and decreasing. And
now?
However, during Omicron, when they said infections are increasing, that was true. Then they said hospitalizations were increasing. I didn't see hospitalizations from Omicron increasing. I saw people being admitted who just randomly had COVID-19, who maybe had a psychosis episode or they had missed their dialysis. But I think that our system had a little bit of trouble distinguishing between, people who were being admitted for totally random things and had COVID-19.
This is people with COVID-19 as opposed to for COVID-19.
And I don't think that was a serious problem in 2020 or through much of 2021 and maybe till the end of 2021. But by February 2022, I would say that they were by far the majority of COVID-19 hospitalizations. In fact, for me, since February of 2022, I have not admitted a single COVID-19 patient. So that's about a year and a half since I've admitted one. And when I speak to my colleagues about this, that's quite similar for them. Maybe, one reports, a handful would report, oh, I've admitted one, I admitted one 2 or 3 months ago. And they're like, I don't know what alley this man must have crawled down to get this old COVID, but it's quite clear to the clinicians, who are treating this that the disease has fundamentally changed. With Omicron. It's not causing hospitalizations at the same rate. And this is not just my own personal experience. There's a study, I believe, out of Denmark that was showing that something about 75% of their COVID-19 deaths were not COVID related, not related to COVID-19. There's a talk from the CEO of some Los Angeles hospital who was saying that they were saying that 90% of their patients in the ICU who are COVID-19 positive are not there for COVID-19. There has been some, besides that published article and this CEO's talk, there has been some mention of it, but it hasn't been that publicly discussed. I feel like there's still a great fear that the disease is causing hospitalizations at these great rates. But I personally, I don't see that, and I don't know anyone any clinician who has been seeing that.
Yeah. So you're not seeing the cytokine storms. You're not seeing the soggy lungs with acute respiratory distress syndrome. You're not seeing the ground glass opacity, but you are seeing people who have got comorbidities being admitted with those comorbidities.
But not for COVID-19.
Yeah.
For, they had something else that happened to them.
Yeah.
Could it be that, I mean, you would need to do a lot more research, but could it be that COVID-19 is increasing these other things as we know the old one did? And maybe but it's not the classical syndrome like we were seeing before. And that's another concern right now for the COVID vaccine of talking about for boosters and such. Because if we're saying it's not stopping infection, even the claim that I questioned if that's even true, if its only purpose is stopping hospitalizations and death,
no one's being hospitalized.
If it's not causing hospitalizations, then I am curious to know then what benefit it would offer. If it's not, if that's the case. So I still don't know actually, and I would like to see a trial that demonstrated that the COVID vaccine boosters are reducing hospitalization and death as we as is publicly said by many of our governments.
Yeah, we're being protected against something that's essentially no risk at all, and even then we're not really being protected, and we've got the adverse events. It's a very bizarre situation we seem to be in at the moment.
Yes,
but briefly, Joseph, just to finish, if you don't mind, the FDA, you've done an update release about the FDA's thinking on this. Now they're using near real-time surveillance, or so they claim, for vaccine safety. Is this working? Are we getting vaccine safety data in near real time?
So yeah, the near real-time surveillance that the FDA has published on it was designed actually by Martin Kulldorff. He's one of the main authors on the original paper that did near real-time surveillance. The purpose is to identify serious harms by this vaccine rapidly while it's being administered, to basically stop it if necessary, to withdraw it if necessary. They published the first publication of this was 21 months after the vaccine was authorized. So the majority of most countries have already taken the vaccine at that point, and many have taken a booster. I believe it was probably the fourth or fifth booster was being recommended at the point of publication of this near real-time surveillance.
So by near real-time surveillance, the FDA mean a 21-month delay.
Yeah. To be fair, they put it in quotes.
I mean, it's laughable. If it wasn't so serious, this is laughable.
Yeah.
It's just.
It's not ideal, no. But
yeah, it's not ideal. No, absolutely. Is there a risk of false positives in the FDA data, that something could be thought of being an adverse event which actually really wasn't, or is there a risk of false negatives?
Well, they discuss it very in detail in their paper about that. They designed their surveillance to avoid false positives, and they made multiple different decisions along the way to avoid false positives. And there's various things they could do and how they do their statistical testing. They also said that they had a group of anonymous experts who judged each adverse event of special interest that they were looking at, and said, okay, if it has less than a relative risk of 1.25, so a 25% increase, if it has less than that, it's not clinically significant. They didn't explain how they determine that, but things like heart attack and stroke. So if you have like a 24% increase in heart attacks or strokes, they determine that to be not clinically significant, which I find strange, because we have drugs such as a statin.
I also find that strange.
Yeah, we have drugs like statins, for which we know In people who've had heart attacks, they reduced their chances of heart attack by about close to 1%. And so why are we even using a drug that reduces heart attacks by 1% if it's not clinically significant to do so? It's a relative inconsistency I see between those two things. And so the false positives that they're trying to reduce, I understand, because if you find a false positive for a harm,
yep, it would make the product look worse than it actually was.
Yes, yeah. And you can maybe even withdraw a product unnecessarily that has all this benefit. And that's definitely their concern. And but the problem is, for surveillance studies, a false positive is actually not that bad, because what you do with a false positive is you just study it again and you determine if it's a false positive. Because if it's a false positive, when you study it again, it will go away and you'll realize that it's a false positive. However, with false negatives, which it just so happens, if you design a study to avoid false positives, it's like a dial, essentially, where you could either avoid false negatives or avoid false positives. But you're going to, whatever you dial it one way, it makes the other one more likely.
Yeah.
So they dialed it all the way towards avoiding false positives, which means that there's a possibility for false negatives. The problem of a surveillance study is
actually missing significant events.
Missing real harm, but you don't know it's there. Yeah. And if you do that with surveillance, the problem is that if you miss a false negative, you don't do an additional study to identify that to confirm that false negative, because you don't even know that it happened.
You don't know what you don't know.
Yes, you don't see it. So with a surveillance study, typically you would actually want to turn the dial towards avoiding false negatives at the cost of false positives. And so I find it concerning. Actually, we found it. Me and my co-authors for that, we wrote, it's a peer-reviewed critique of the surveillance system that is highly concerning. They in fact, they didn't even in the younger age group, they failed to identify that Moderna was causing that the Moderna vaccine caused myocarditis. And when we know that is occurring, it shows that your system is simply not adequate for doing this. If it can't identify something that is increasing, we know it's an obviously associated, it's not even a debated thing, it's increasing the relative risk so high that everyone who studies it identifies it. So the fact that it didn't identify it, it didn't signal it, that should raise everyone's red flag that this system is not adequate for surveillance for our population.
Some may talk about difficulties in adequacy, others may say a complete waste of time and a racket, but people will interpret that differently.
There's different ways to interpret it.
Yeah. The FDA seems to be defining what is minimally clinically significant. Things that are minimally clinically significant, if there's enough of them, would be immensely clinically significant to me.
Well, yes, I think that's actually what their numbers are based on. They're saying if you have a 26% increase in heart attacks, that would be clinically significant because it would affect so many people. But if you had 10% or 15% or 20% increase in heart attacks, it's too small of a number of heart attacks that maybe it's not. I presume they don't explain it very well. How these experts determined these numbers, and the fact that most of them are just 1.25 down the road suggests that they didn't use any sort of mathematical equation for determining the background rate of saying, okay, this many more of these is bad. So, I mean, I don't know how they came up with it, but they said that they said that they were experts.
And are they collecting data from all 50 states?
No, the data for the near real-time surveillance is based on insurance data from 7 states. So
they're only missing out 43 states.
They are missing out in 43 states. But I don't know if they don't have the data for the other 43 states. The biggest concern from any sort of epidemiological evaluation is that they didn't say how they chose those 7 states, so they can choose them how they please. And when you can choose things how you please in epidemiological studies, you can find results that are there, that you could find results that aren't there, or you could avoid finding results that are there. It's hot, for example, the CDC, they did a masking study, I know, where they showed that masking, I think in school, I want to say it was school masking or mask mandates were effective when you looked at this 6-week or 2-month this period. And then another group did the study and they expanded it to 6 months and the effect went away. So it's like when you're just choosing random numbers and you're not when you're just choosing random data sets and not explaining where that data is coming or why it was chosen, it leads that up to, the readers for their imagination. They can come up with any reason that these data sets were chosen, which is problematic.
43 states, don't worry about it.
It's also possible that states, because they have different demographics,
of course,
you can presume it's possible that the vaccine's harmful in certain demographics that some states may not have. So you would really want to make sure that you're looking at it, lots of subgroup analyses and such. But if states just don't have a high percentage of something, then you just won't see it if it's specific to that disease state, or that comorbidity.
Florida, you might have more older people. Oregon, you might have less older people.
Exactly.
Yeah.
Exactly. Yeah. Or even Alaska, you have more males than females, I know, and that would be there's just different demographics between the states that
different.
It's not wise to choose
different
7
comorbidities, different occupation groups, lots of differences.
I would just want to see a reason why.
Sure.
I think there needs to at least be a rationale, and they probably have one, but they didn't publish it, and they didn't respond to our critique.
Yeah. So all the different places the FDA are getting data from, is this all pooled into a central spreadsheet for pooled centralized analysis?
That's actually one of the worst parts of that near real-time surveillance. So they have 3 insurance data sets, and they typically you would take them all together, add them all together to increase your power, because that actually what that does is that increases that will decrease your chance of false negatives and decrease your chance of false positives. Yeah. So if they're so concerned about false positives, why they to run it 3 different times? That's a disaster. That's bad for false positives in a sense, but it's also bad. It's also bad for false negatives. So, and typically you would pool those 3, all the data sets that you have, and
it's like a meta-analysis.
Yeah,
my first year students know that the more people you have in the study, the more likely you are to get valid data out of it. This is pretty basic stuff.
It's yes and no. I mean, it gives you more power, but if there's confounders within the data set already, that just gives you more likelihood to identify the confounder that exists. So it's possible. More isn't always better. You want it to be as well controlled as possible and such. But yeah, you're more likely to find the difference between groups. That's for certain.
Yeah. And is all this data from the FDA published for independent peer review and analysis?
No. That they have it published in their journal article that the individual data is not available for reanalysis from those 7 states, or if their data exists from the other 43, it's not been made public. I also would point out this pooling thing. I don't know the reason why the FDA didn't pool theirs, but they, how they have it in 3 different, cutting it up into 3 different data sets. It reminds me of this technique that I think is still probably done by companies where when there's a lawsuit for maybe a toxin that they put into the water or something like that. They'll go to the trial with like 5 or 6 different data sets saying, look, our toxins doesn't cause cancer. When you look at it, we looked at it in 6 different ways, and it didn't find cancer in any way. But if someone takes those 6 trials together and you put them together, then woe and behold, the toxin will cause cancer. But they keep them separate to win a lawsuit. And I don't know that I can't imagine that the FDA would do something in the same manner as as a company trying to avoid a lawsuit. However, it is. I just find it strange that they would do something that is very similar. So like I said, I don't. They have not explained their rationale for why they've done it in such a fashion. But I would love for them to explain that. That would be excellent for us to know.
Quite a few strange things, really.
Yeah.
It's fascinating that research is science and a bit of an art form, isn't it, really? The whole topic of research, and that it can be used for immense good, but it can also be used to present a particular perspective in the right hands. Double-edged sword.
Oh, yes, it is very much the case. I mean, it is something that's always bothered me in science when you read through it and you read activist science, in a sense of, people who are convinced of their result, and they go around designing a study in such a fashion to obtain that result. And you see it with financial interests, and you can also see it with people who just have, for whatever reason, a bias towards one result being the case. But cleverly designed studies can often lead people to the wrong conclusion. It's why it's so important that any study that people publish, that they release they're transparent, and that they release their data for other people to analyze. And that's definitely true for anything with financial interest, but I think it's true for even non-financial interests. Like our group, for example, we've been fully transparent with our data, and we would ask that the FDA be transparent with the COVID vaccine data, and Pfizer and Moderna be transparent. There really is not a good reason that we shouldn't be, if we're all here have the same goal of trying to identify the truths of what we're doing here with our clinical medical interventions. Like that's our goal. That should be the goal of everyone involved. But and because I understand that if our study is incorrect, right, that I want people to take our data, replicate our study, and show us that we're wrong. And I would love for someone to do replication studies and, show that our study is right, or show that we got some things wrong. And that would be very useful. That's the right way to do science, is that we, keep it transparent, let it be repeated. Let's figure out what's true, what's not true. But things are a little harder right now with that.
All we want to do is discern the nature of reality, right? Work out what's efficacious, work out what the dangers are for the benefit of everyone, which is what your work has done. So on behalf of, the entire populations, really, of our countries, thank you for everything you've done. And we wish you well in all your endeavours. It's an impressive piece of work, and also impressive answers from the interview. If you got to the end of it, well done. So thank you for watching.
It's been a pleasure.
Thank you, Dr. Freeman, from all the way from Louisiana. So great to talk to you. Thank you.
It has been a pleasure. Maybe we could do it again sometime.
Hope so. Yeah. Thank you. Thank you.